Hello, and welcome to this brief overview of the fine needle aspiration procedure involving the thyroid gland. This presentation is an individual submission from Diploma MSc. Before beginning the presentation, please liaise with the description section of this video for several important disclaimers. In this presentation, we will review what fine needle aspiration, or FNAs are, why we perform them and what we hope to achieve, what the limitations, cautions and contraindications are, how ultrasound scans or USSs are involved, and how the procedure is generally performed. In lay terms, FNA involves the insertion of a needle into a tissue to obtain a sample for analysis by pathologists. Several tissues can be assessed, of which the thyroid is one. FNA is a minimally invasive and safe procedure, typically undertaken in outpatient settings. FNA provides healthcare providers with detailed information about the etiology of clinically suspicious lesions. They are especially useful in distinguishing benign from malignant lesions. For example, in thyroid cancer, the detection parameters with FNA include a sensitivity of up to 98% and a specificity of up to 100%. It is generally considered safe and cost-effective. FNA is performed in several clinical circumstances, which are outlined in detail here. Although safe and effective, FNA is limited by the technical experience of the operator, or circumstances where the thyroid nodule is not easily palpated. In addition, FNA does not always correspond with the clinical picture, which may necessitate further imaging or resampling. A variable percentage of FNA cytology reports are indeterminable. FNA carries a small risk of localized bleeding, or referred pain to head or ear, termed otalgia. A coagulation screen of the patient should also be undertaken, in order to rule out bleeding disorders, which may result in persistent hemorrhage. The coagulation status of patients must also be established. Vascular structures must also be avoided during aspiration. As the procedure and its complications are minor, there are no absolute contraindications to FNA recognized in guidelines or literature. Ultrasound scanning is preferential when a thyroid-derived lesion is palpable. It also increases the accuracy of sampling, thereby permitting successful aspiration. USS-guided FNA has been demonstrated to carry a lower false positive rate than a palpation-only approach. After a patient is informed of the procedure's basis, risks and possible complications, consent must be obtained before it can be undertaken. FNA is routinely done on an elective basis. Those patients on anticoagulation or antiplatelet therapeutics must discontinue these beforehand. Once the thyroid lesion in question has been identified, an aseptic technique followed by USS and the application of local anesthesia must be pursued. Then, at least 2 samples should be obtained. This schematic demonstrates a transverse section of the thyroid gland at the level of the isthmus, where the implicated structures and general principle of USS-guided FNA is shown. In summary, FNA is safe and routinely carried out in the outpatient environment on an elective basis for the investigation of suspicious thyroid nodules. The accuracy of FNA is enhanced by the use of USS simultaneously. Finally, FNA may need to be repeated if changes to the clinical picture or an indeterminable result are present. Thank you for your time and attention.